Good morning, everyone. Thank you for joining us. I think a few people trickling in. Just a few opening comments. My name is Shan Rupnerine of the Alberta Medical Association. I'll begin with land acknowledgement. The AMA respectfully acknowledges that we are privileged to live and work on the traditional lands of diverse, distinction-based Indigenous peoples, including the Anishinaabe, Nez, Nahiawuk, Cree, Net-Itsitape, Blackfoot, Otimisawuk, Métis, Sioux Nakota, Nakota, Tsuut'ina, and more. This land has been gifted with many names, including Treaties 6, 7, and 8, the Métis Nation within Alberta, its Otipemisiwak Métis government, the 8 Métis settlements and its Métis Settlements General Council, and the homeland of the Métis. The AMA honors the vibrant histories, languages, and cultures of the First Nations, Inuit, and Métis people of Turtle Island, now known as Settler Canada, who came before us and continue to thrive here today. We invite everyone to reflect further on how you can contribute to meaningful reconciliation, including actions that move us towards holistic health for all the relations who host us. Our speakers today for this briefing are Dr. Paul Parks, President of the AMA, who many of you know, and introduce you to Dr. Lloyd Mack, President of the Section of General Surgery within the AMA. I'm going to ask them to begin in just a minute, and then we will hold a Q&A session following the comments. I'll moderate that. We will be using the hand raise tool, not the written online. We are recording the presentation portion of the meeting, and we will be posting it later on the AMA website. And I have sent the issue paper regarding this general surgery advocacy campaign to those who were on the registration list earlier today. If you do not get it from me this morning, you can email media@albertadoctors.org, media@albertadoctors.org, and I'd be happy to send that to you, and it will be available on the website. Thank you. At this point, I will then turn it over to Dr. Parks to begin the comments.
Thanks. And Shan, I don't know if you saw there was a question. Are we able to allow them to record as well? Or I just saw a comment about that. Or will they have to get it from you?
They can record. Should be
all
right.
Okay.
Yeah, easier.
Sounds good. There you go. Okay, perfect. Awesome. So good morning, everybody, and thanks for being here. So back in May, I compared Alberta's acute care system to an expanding aneurysm and was questioning, could it rupture before we could stabilize it? And I said that clinical and operational channels through which patients flow are severely weakened, and that's increasingly difficult to support and stabilize care that Albertans deserve and need in our hospitals. Since then, the Alberta Medical Association has been shining a light on access block and issues regarding cancer care, but there are definitely other areas within the healthcare system that require and deserve attention. That's why we're launching another 6-week information campaign, and this time focusing specifically on general surgery. And many Albertans may not know exactly what a general surgeon does, and Dr. Mack is here to explain in detail if you have any questions. But general surgeons, to put it succinctly, are essential and lifeblood of surgery in our hospitals. Hospitals simply cannot function without having general surgeons available, and they're essential to have them available in our hospitals 24/7. From head to toe, they provide an incredible wide range of surgical services. And one of the most common ways you'll end up being seen by a general surgeon is when you show up in emergency departments like where I work, where you have unplanned events and you require urgent or emergent surgical care, often in the middle of the night or on a weekend or on a holiday. I can tell you our long weekends in May and August are particularly very busy for things like trauma and the need for emergency surgical services. And so in those scenarios, we'll stabilize you in the emerge, but it'll be the general surgeon that will be coming to your aid and offering and providing the surgical care. And unfortunately, Albertans are used to long waits in the emergency departments, and that's not a good thing to be used to. But we're working on that, and we're trying to make strides to try to improve that. And that's a whole other set of issues. But I think what might be surprising to a lot of Albertans is that if they would expect that maybe they'll have to wait to be seen in the emergency department, but that once they require surgical services, they do expect that once they're in, there'll be surgeons there to take care of them for their life and limb-threatening illnesses. if you need surgery, they expect that they're going to get it right there on the spot in a timely manner. And unfortunately, we can't always meet those expectations in Alberta anymore. There's an increasing chance that you might end up being seen and stabilized in one emergency department and then unfortunately have to be packaged up and put back in an ambulance and transferred to another hospital where they have the adequate surgical and support services available so that you can actually get that general surgery in a timely manner that you require. And this is something that's titled diversion, and it's unfortunately happening more and more, and it obviously means more delay, and it can cause very serious complications. I'm going to turn things over now to Dr. Lloyd Mack, president of the section of general surgery, and he will explain to you why this is happening, why we're all so concerned, and what he thinks needs to happen to turn things around. I'll be back for some additional closing comments at the end, and then obviously leave lots of time available for you to ask questions of myself and Dr. Mack. So Dr. Mack, over to you.
Well, thank you, Dr. Parks, for the introduction of this issue. Dr. Parks has explained well what general surgeons do and some important roles we fill in the system. We are a large group of subspecialty surgeons, and we perform many different types of surgeries. All general surgeons go through a 5-year residency training program after medical school, and almost all in Alberta have done additional subspecialty training beyond that. One of the subspecialty areas is surgical oncology, which is what I practice. We perform surgery on the cancer patients that Dr. Parks has been talking about over the last 6 weeks, such as breast or colon or most types of cancer in which surgery is a part of the treatment. General surgeons may also do other areas of subspecialty, including things like colorectal surgery, liver pancreas surgery, a full range of subspecialties across the province. As Dr. Parks noted, importantly, we do most of the trauma as well as emergency surgery provided. Things we see in the emerge in the middle of the night includes things such as perforated appendicitis, perforated ulcers, bowel obstructions, bowel perforations. It's usually the general surgeon on call who will come at 3 a.m. if you've been in a car accident or some other event that brings you to the hospital. Sometimes we are called to perform emergency surgery on patients who are in the intensive care unit. It's not an exaggeration to say that hospitals just can't run without general surgery care. So I really want to talk about the situation that Dr. Parks referenced, as I personally think this is a crisis. This is a situation where you arrive at the emergency department, you need immediate surgery, and there is an operating room available, and there is a general surgeon, such as myself, available, but you still can't get your surgery at Hospital A at that time. Instead, you are put back in an ambulance and sent across town to a different hospital, Hospital B, that can provide the surgical care you need. This is what's known as diverting patients or diversion. Essentially, one hospital is closed. It's closed for general surgery emergency patients. What's the difference between Hospital A and Hospital B? Well, it comes down to availability of staff who work with the surgeon and the support team. Some of these we call Tier 1 supports, recognizing their importance. They could be resident physicians, clinical assistants, physician assistants, or nurse practitioners. A whole number of team members who need to be there to look after the patient during surgery, but as well before and after, as well as to assess other patients in the emergency room or the intensive care unit while surgery is happening. For scheduled surgeries during the day, the severe lack of anesthesia is a separate but equally worrisome problem. It's causing cancellations, as many of you have heard, of up to 20 to 40% of operating room capacity in the hospitals in Alberta. So the chronic shortages of healthcare professionals that you've been hearing about are hitting general surgery patients particularly hard. If those team members aren't there, I can't accept the patient from the emergency room. The ER is effectively closed to surgical patients, and the patient has to be sent elsewhere, typically to another hospital that is already busy, and now risks becoming overwhelmed as diverted patients continue to arrive. And unfortunately, these patients should not be waiting. When patients present needing emergency surgery, I think of the clock as ticking. Delay means probable complications. It may mean more severe illness very quickly, and in the worst case scenario, a patient can die from these illnesses. So diversion of patients is happening frequently. It has become common and the rate is increasing. I looked at data for one of our medical zones where nothing like this has ever occurred before. From January through March this year, the hospital was in diversion mode with general surgery closed for 20 out of 90 days. This includes a hospital that sees from 5 to 15 emergency general surgery patients every 24 hours, and multiply that by 20 days. Sometimes two hospitals were closed on the exact same time period. You can see why we are worried when up to 300 cases could be diverted or potentially sit in the emergency room getting worse until the next day or until they're diverted over a 3-month period. And I know these numbers continue to go up. So ideally, we need to get ahead of this problem. It's not safe. It's clearly a poor use of resources shipping patients around the cities. The first step is to make sure that the public understands that this is happening. It's a big part of what we're trying to accomplish today and in the weeks ahead. We all know that the emergency wait times are on the website. We can tell how long it is to be seen, but you may not know that once you get there, you cannot see the required surgeon if that's the problem you have. Then we need to invest to ensure that we have those important tier 1 supports, clinical assistants, physician assistants, nurse practitioners. We simply can't do surgery or our jobs without them. And if we can't do our jobs, and when we're scrambling to try to do our jobs and the morale becomes down, this province just does not look very attractive for young resident physicians training in general surgery. They're the workforce of the future, and naturally they want a safe and sustainable place to practice. And unfortunately, that's not the way Alberta looks right now. So we need focus and a plan for investment on workforce, for anesthesia, for scheduled surgeries, for tier 1 supports to help with emergency surgeries, for surgical nursing and other areas. We have not been growing the general surgery workforce with the population gains in Alberta, or replacing them as quickly when they retire or leave the province. It's only going to get worse if we don't start taking action now. So I'll wrap up there and perhaps send it back to you, Dr. Parks.
Thanks, Lloyd. I'm not going to take up too much more time before we go to questions, but I do want to make a comment that so what we're talking about now and what we want Albertans to be aware of is that this isn't new. So diversions have been occurring, since even January 2023. They've been growing, actually. One of the things that's really concerning is I think AHS has very, very good, robust data on how often they're diverting and what kind of delays it's causing. But it's I don't know that it's publicly available. But what we're experiencing and seeing more and more is that this is becoming an occurrence in all of the zones in different ways and growing and becoming more difficult and more problematic for patient care. So, this isn't, unfortunately, this isn't a new issue, but it is becoming critical and is having very significant impact on the lives of Albertans. And so I'll also remind you that we do have a AMA, and Shan is sent out to some of you, but if you don't have our general surgery issue paper, then just contact Shan and she can make sure you get that as well. And then I'll just thank everyone for coming. And then, I'm very grateful to the media outlets and journalists for helping us shine a light on this, because it is something that I think Albertans are not aware of, that when you come, as a real concrete example, when you come see me with your pain in your belly and quickly we say that's an appendicitis, and we want to get you taken care of as quick as we can so it doesn't rupture, so it doesn't cause complications, so it doesn't actually may even be life-threatening. You might not realize that there's not a general surgeon at the site, that the emerge doc seeing you. There may be a general surgeon, but there's not the team, or there's not the ability to take care of that patient in your facility, and we have to then put you in an ambulance, and that in itself, there's ambulance delays around timing to get ambulances. It can take hours and hours where we have you diagnosed with a time-sensitive surgical condition, and there can be very significant delays, and this is growing. So with that, I'll just say I really appreciate the ability for you to be able to talk to you guys and to educate more on this issue, and I'll open it up, and I think Shan's going to monitor the hands there for questions.
Yes, for sure. And I'll try and keep things in order. And yes, I did send out that. If you do not have the issue paper, email media@albertadoctors.org. I'll get that to you, and we'll get the recording of this up on the website later this morning as quickly as possible for you. So I think we've got Kay Skulski from CTV up first. You want to come off your mute? Please identify yourself and your media outlet.
Hi, yes, it's Shailan Skolsky with CTV News in Edmonton. Thank you so much for taking my question today. I know you touched on it briefly already, but if you can outline for me specifically what jobs are the highest priority that we need to fill, and do we even have a number in mind of how many we need of those professionals?
I'll let Lloyd jump in there. Go ahead.
Yeah, I could try first. The tier 1 supports, really, if I'm on call as a general surgeon, there has to be at least 2 support people on as well. So if we're in the operating room, there's 1 person in the operating room, which is often a surgical resident, or more and more it's become a clinical assistant of some sort, which is the jobs we're talking about. In addition, there has to be a separate person in the larger hospitals in Edmonton and Calgary in order to quickly respond to the emergency room, which typically will have additional patients being sent our way, or perhaps to the wards or the intensive care unit, depending on where the problems are. In terms of numbers, to be honest with you, it's hard to know, but if there's 20 to 30 diversions every 3 months, it gives you a sense of the workforce that's required across the province. Unfortunately, with the growing population in Alberta, as well as the crunch in terms of the number of spaces in the emergency rooms, we just haven't kept pace. We haven't grown proportionally with these tier 1 supports.
Yeah, and I would add too that that's a great question for AHS, because you would hope that they would have very robust data on what their workforce looks like right now and what they actually need for the tier 1 supports. I'll say as well that there has been some changes around residency training focus versus service focus, which is a reality. It's a good thing for the residents, I think, and it's going to be the future. So planning for how to do the tier 1 supports in relation to those changes in residency is critical. And then another piece that this is very complex. So Dr. Max mentioning the tier 1, but of course we also have issues around anesthesia as well, anesthetist being available, and having ORs that are actually available in the hospitals and surgeons in the hospitals for those cases at 2 a.m, but we don't have an anesthetist, or we don't have the tier 1 supports to do that surgery. So we actually have the resources and the ability, we don't have the workforce.
Okay, thank you. Next up, we have Clarice Charion. If you'd come off mute and identify your outlet, ask your question. You might still be muted, Clarice.
There you go.
Oh, hi, it's Brianna from Global Edmonton. Clarice is our editor who signed us on. When it's a workforce issue like that, I mean, we've heard the province say that they're doing what they can to try to attract new talent. What more can and should be done, especially in the short term when we need these people tomorrow?
Yeah, well, I'll jump in quick, but one of the things, so I think actually starting with a little bit of transparency around how often diversions are occurring and what the workforce issues really are. The second, though, we did give a hospital stabilization plan to the government. So one thing I'll say is this: to be fair, this has been growing for years, and this problem has been growing and growing, and some of the solutions have been neglected over time. And then the pandemic really changed our workforce across the country. But in December of last year, we gave a hospital stabilization saying, here's one example that would be able to help mitigate some of these difficulties, like increasing the alternative funding for our hospitalists, that would actually bolster being able to recruit into those positions and supporting it. Some of the funding and models around clinical assistance as well. And then also after hours care, because one of the things that's more and more difficult is that these are not all of these aren't necessarily predictable. There's obviously scheduled surgeries, but within the general surgery realm, they have a lot of surgeries that are not necessarily predictable or have to be done after hours. And so those after hours modifiers and incentives are pieces that we've said, hey, this would mitigate it while we can create an environment in Alberta where we can recruit the best in the world to support our teams. And unfortunately, we haven't moved forward on a lot of those solutions. So I'm not sure, Dr. Mack, if you have other things you want to add or.
Yeah, I think you gave a very good summary. I'm a former program director for surgical residents, so I do think surgical residents are a big part of this. I must admit to everyone that there's been less jobs for general surgeons in Alberta, and generally it hasn't kept pace with the population, and therefore probably 5 or more years ago, we weren't training quite as many surgical residents because there was less positions. And in addition, now we're having trouble recruiting surgical residents, both in Calgary and Edmonton. And so that's becoming a real issue, and especially if you want to retain quality people. So it is an ongoing issue. I think the tier 1 supports potentially could be recruited more quickly. There are a number of clinical assistants or people with background that could do these types of roles, but investment's definitely required.
Okay, thank you. Next up, we have Jennifer Lee.
Hi, guys. Thanks for taking my question. I'm wondering about the trauma diversions at Foothills. Maybe you could explain what's happening with that and what the implications are for that, given that, Foothills is the level 1 for Southern Alberta. Like, how serious is the situation if we're seeing trauma diversions?
Dr. Mack, you go ahead first. I have thoughts, but go ahead first, please.
Yeah, first of all, it's scary, obviously. Even the fact that we're talking about diverting for a trauma center. It's the same issues. Unfortunately, it's the same support group. So there is a trauma surgeon available. Typically, there's an operating room available at short notice for trauma patients, but we often are not having the supports. Most of the time, the workforce for general surgery and trauma is somewhat interchangeable, and therefore we've been prioritizing trauma over general surgery, and that's why there's more general surgery diversions, to be honest. But at times we've had this scenario where there's been trauma diversions as well. The reality is a true level 1 multi-system trauma, people are going to come together, they're going to find people last minute if necessary. But the fact that all of the less urgent things will potentially sit or be diverted or go to non-multi-system trauma services. Let's say you have an isolated head injury, there's still a neurosurgeon, for example. But that multi-system type trauma care is definitely being compromised.
Yeah, and I would amplify this. I think our general surgeons don't like to speak about this, and none of us do, because it's very worrisome. I think AHS is trying its best to mitigate, given the situation that we have, and trying to minimize our major trauma center diversions as much as it possibly can. But the fact that it's ever happening, I'll be really blunt that these are the patients that need timely, life-saving care, and any delay for their cares or any need to actually have to package them up and move them to another center when they could be quite unstable and really time is of the nature. It's very concerning that it happens ever. I think our teams on the front lines are absolutely, as Dr. Mack said, we do our absolute best to improvise and to try to prevent those kind of situations, but it's getting to the point where that's more and more difficult. And I think that's why this discussion is coming really needs to be robustly talked about now is that we're in an environment where these diversions are just growing, and the fact that our major trauma center for all of Red Deer South and the entire province has diversions. That's not acceptable. We have to do better.
Can I ask a follow-up?
Sure.
So where do these patients go then? If Foothills' trauma is on divergence, they go to Edmonton, like where are they?
To be honest, I'm not sure it's a policy. We do actually have policies for diversions, unfortunately, because they've become so common. But for a trauma center, I don't think we're there. So I can think of a couple of examples where patients went to the Peter Lougheed, for example, but that's not a trauma center. So again, it's quite scary. This is unprecedented. I don't think this has ever occurred in a trauma center in Canada or North America before.
Yeah, and I would say again, we always kind of try to do whatever we can to do best for the patients. But as we said, the fact that this is occurring even once is huge. It shows how challenging the resource issues are right now. And then the second thing is, this is why I did the analogy of an aneurysm and it's growing. The pressures. If you think about it, we're discussing general surgery, but we're having issues with orthopedic surgery in Edmonton Zone. We're having issues with access to internal medicine, with almost all of the specialties in our hospitals. And if you think about the amount of time and effort now it's taking for us to apply these band-aids for these sick patients in different environments, it's a real challenge in the emerge environment to try to mitigate the fact that we don't have the adequate resources. And so go back to a level 1 trauma center. I mean, that should be something that we have a strategy that it just never occurs that they have to divert.
Hey, thank you. We've got Edith Boisvert, and I do have Tina Kennedy and Sean Amato queued up. I'm noting that you're unable to raise your hand, so got you in the queue. Over to Edith, please.
Maybe a mute still, Edith?
Yeah, might still be muted. It's Monday. I'm not hearing Edith just at the moment. Maybe we could go to Tina and then we'll come back. Tina Kennedy, can you go next?
Hi there. So I'm here in Northern Alberta in Grand Prairie, where we see diversions all the time from hospitals around us here in the Peace Country. We get a lot of emergencies that come here as well, as do some other locations. How is this going to affect Grand Prairie now?
I'll jump in quick there. You unfortunately in our rural and regional centers, you get the trickle down effect as well, as that as best as we can to try to put resources and protect the major tertiary centers, it has a ripple effect, because if you're having a hard time recruiting and getting those supports in Edmonton and Calgary, for example, I'm sure I don't have to explain to you that it's even harder to recruit out into the regional and rural areas. And Grand Prairie is a perfect example of that. That's a huge catchment area. You have lots of trauma in there, which would require general surgeons regularly. You have lots of the regular type of surgical illnesses as well, and it's a big catchment area. And in fact, now just in the news, there's actually closures at the Grand Prairie because of lack of anesthetists, even as examples. But I think what the risk to those regional centers is a growing threat, because as these diversions occur more and more, and we try to move around resources to protect the tertiary and urban centers, then the regional centers are at higher and higher risk. And then it means for those patients, not only does the diversion mean delays to care, but a lot longer transport times. And these patients, I'm as an emerge physician, I've been involved in STARS transports and those type of transports of these critically ill patients long ways to the next facility that can do these surgeries. And that in itself is a very challenging process, and it's a risk for the patients as well. So as this grows, we become more and more concerned about access in the regional centers.
Yeah, and I think there the one of the highlights is our anesthesia colleagues are, unfortunately, we have not recruited or kept pace with enough, which is being particularly felt in places like Grand Prairie, Red Deer, Lethbridge, and surrounding areas where there's huge proportion of operating rooms staying empty during the day because of lack of anesthesia resources, unfortunately.
All right, well, we had Edith in the queue. I understand she's having tech problems at CBC, so Jen Lee is going to ask her question for her, and then we will go to, I think we have Global with Clarice's account lined up again, and then Shilan has another question. So Jen, do you want to ask Edith's question, please?
Sure, thanks, guys. So Edith is wondering, what is the range of government responsibility in this situation, and what is the responsibility of hospital admin? And then there is a secondary question, maybe if that's okay.
Yeah, I mean, that's a great question to ask government, ask the Alberta Health and AHS. I think part of this would be one of the struggles right now is, as I said, we, as the AMA, we did give a hospital stabilization plan to the minister and Alberta Health in December, saying a lot of the stuff we need to start moving on some of these funding models that will help temporize and mitigate, that will help us so we can recruit and retain. We've been working collaboratively, obviously working on a bunch of other issues within the healthcare system, including primary care, but we haven't moved very well at all really on that hospital stabilization model, and that just keeps putting us further behind. But I do think it's an excellent question that we should be discussing publicly quite, openly, because we're in a scenario right now where some of these issues are definitely related to the funding models and the incentives around trying to be able to recruit and retain and be competitive compared to the rest of the country. And so adequate budgeting for Alberta Health Services do they have the adequate budget to be able to pay the clinical assistants appropriately and the hospitalists and all of those tier one supports? And then of course, though, to AHS, it would be, what is the workforce plan? I've been talking about this for over a year, saying we have no concerted workforce planning that's done in a coordinated method in our province. It should be clear that I think many bodies are trying to do some workforce planning, but we're not doing it in a big coordinated manner where all of the major bodies are involved in this workforce planning, and that it's done in a transparent manner. So it's a very complex system and a complex question, but I think those are fair questions to ask the ministry and Alberta Health Services.
I don't have a lot to add there, Jen, except that the concern I think that shows is that we have a policy on how diversion works now, because it's come so commonplace. But I'm less aware of boots on the ground. How do we solve the problem? I know that people are working on it. I just feel that we have to make everyone aware that it's really a crisis situation, and the time is imperative.
Thanks. I think her follow-up question was about what can be done right away. So like in the next month or two. Some of the stuff is maybe longer term thinking. Like, what is there anything that you guys would like to see that? Sorry, I muted myself there. That could be implemented soon.
Yeah, I'll let Lloyd answer as well, but I'll just say that I think some of the funding models and some of the pieces that we've given as, again, money isn't going to solve everything, because we still need the human bodies. We still need skilled, trained people to be able to plug into those roles. And so first thing is creating an environment where Alberta's the place. This is a supply and demand issue across the country and across the world. Finding these trained human beings is becoming more and more difficult. So we have to be the place that is competitive and the place to come work. So by building that environment where we mitigate some of this, so diversion isn't happening again and again and again, and the environment is so chaotic, so people don't want to come and work here. But part of the model piece that we've said is the funding incentives that we've provided to government, saying this will help at least stabilize and create an environment that we can go forward, that we can actually find the people, train the people, do some of those things that'll allow us to create a plan going forward that will allow us to grow that workforce in a meaningful way that can protect these services.
Yeah, I might just give a concrete example. We do attract residents from around the world, and we often train general surgeons for other countries. The interesting part is if they stay and do subspecialty surgery, they're often not able to provide on call as a tier one support, even though they're fully trained surgeons, partly because of issues with our college or with recognizing licensure and things like that. And there is a pool of these people available that would be willing in a fairly quick fashion, I think. If you can imagine, just cutting the diversion rate by 10 or 20% would make a big difference night to night.
Okay, thank you. I think we had Sean Amato in the queue. He just hasn't been able to raise his digital hand. So go ahead, Sean.
Hello, Sean Amato with City News. Thank you for taking my question. Dr. Mack alluded to Alberta not being a very attractive place for health professionals to come to. I'm wondering if you could elaborate a little bit more on why that is and whether or not the UCP government's, I guess, coziness with right-wing extreme people and conspiracy theory people and the like is a factor.
I can start with the first part of your question. The difficulty we have now is the volume of emergency type patients and less people to look after them. And if you can imagine being a general surgery resident, continuously working, maximal call, basically as many call shifts as you can, providing as much service as you can, potentially getting less education, knowing that your staff or your senior colleagues are in this exact same scenario where they're fatigued, they're tired, it's hard to teach surgical residents when you've been up on call shifts continuously, or you've been having to deal with issues like diversions because of less numbers of people. And inevitably it affects morale. These young surgeons and the young medical students see that, unfortunately, even though we try to promote that Alberta is the right place to come, they do recognize it, and it becomes a more difficult place to attract residents to.
Yeah, and I agree fully with that. I think part of that I think you've all heard me say again and again that we have to change the narrative, and we truly have to change that make Alberta a place that's attractive to come. And I would say that there's no question. I have been blunt about the previous government and Minister Shandro tearing up the contract, and we still have the hangover of that in the background, that we're repairing those relationships now. I think a good relationship with the minister and the premier now between our organization is a positive thing. And it is allowing us to start making strides forward to change that narrative. But I think part of this, and this is why we talk about this, is we do need government to share the urgency on the fixes here. As Dr. Mack said, it's a bit of a death spiral as you have more sick, really, really complex sick patients and higher volumes of them and less people to work with them. You just continue chewing up and burning out your team that are showing up every day to actually see and care for those patients. And then as Lloyd said, when you're a resident coming and looking and you see that environment, it's less appealing to come here, and they see it and feel it. And of course they're then training in an environment that is a bit beyond chaotic and difficult at times. And so we have to change that narrative. And I think one of the first steps, I'll say again, is that admitting it's a significant problem and sitting down and saying these are the very short-term fixes we can do right now that will help ameliorate it a little bit, and then here's some of the incentive and investment we can do up front that can actually stop the death spiral, can stop this from keep getting worse, and allow us to get some breathing space, and then allow us to start to create that environment again where we do have the Alberta advantage, and people want to come and work in our province. And I'll just say one thing again for everybody is that, again, this is about access. So when you get in to see our surgeons and when you get into our trauma centers and into our facilities, you get the best care in the world. I have no doubt about that. It's that as the teams are struggling, it's delays to access and delays to care. And so people, if we could break that cycle, why I bring that up is residents would want to work in Alberta. Physicians would want to come and work in our centers that have amazing resources and skilled people. And it's just that we have to break that cycle.
Thank you. I believe we are now doing some additional questions from people who have asked before, but I think we have time. There was Global via the Clarice account.
Yeah, I just wanted to quickly ask, and sorry if I missed this, but did you have a number of how many trauma diversions there have been, and also what areas of the province are seeing the most diversions?
My sense, I don't have the data in front of me, but the trauma diversions at the Foothills Hospital, there have been 2 or 3 scenarios all this year. At least one of them was solved last minute by basically taking staff from general surgery over to trauma, and then putting general surgery on diversion or closure. That's the numbers. In terms of the place with the most diversions, my sense is, that everywhere in the province has had this issue. My sense currently is that Calgary seems to be the worst one in terms of kind of this becoming commonplace, but many of the sites are struggling more with the anesthesia issues, for example. So it really depends on the center what the biggest issue is, whether it's diversion from an emergency care point of view versus diversion or cancellation of scheduled surgeries because of anesthesia shortage point of view.
I'll be even more blunt. I think that's a question that we Albertans should demand Alberta Health Services tell us. They have robust data on diversions. It should be publicly available, and we should know how often and where diversions are happening, so that people can be aware of how the problem is growing and how it is significant. And so I would urge you to ask Alberta Health Services for those data, like outside of just I do want to highlight like the fact that Foothills diverting major trauma, they may try to respond that happens rarely to never and kind of minimize it. I think in the big picture though, it's like, give us the stats on how often is our Calgary hospitals diversion. I'm aware of stats since January of 2023, and it's been growing, and they have them. So please ask AHS to share them.
Thank you. I think we have another question from Shailan.
Yes, I do. Thank you so much for taking my second question. I wanted to follow up on Jennifer Lee's questions in terms of where patients go. Dr. Lloyd Mack says we've never been in this situation. Am I to understand that essentially diversions are determined or I guess solved on a case-by-case basis based on whatever resources are nearest available? And I guess as a secondary to that, are we essentially approaching a situation where we could envision having to fly patients out of province to get that care because we just can't do it here?
So maybe I'll just clarify the earlier comment. So for general surgery type diversions, we do have a policy or a working group, generally 24 hours before it's going to happen. Basically an email chain goes out to all of the affected people, including, let's say, Foothills. It's happened to me personally. It happened to me on a long weekend. I got an email saying that we are on diversion tomorrow. They let the emergency department know. They let the Peter Lougheed know because our diversions were going to the Peter Lougheed that day. So they let the surgeon there, they let know, and they let the emergency department there know, as well as the operating rooms. So there is a process. I think the exceptional circumstance was the trauma diversion. Because we don't have a policy paper that I'm aware of on how that's going to work. So it reached upper levels, and that's where there was some scrambling for sure on what to do.
Yeah, and to make that, oh, sorry, go ahead.
No, go ahead.
I was just gonna like to make it really clear what Dr. Mack's talking about is that there will be times, as he said, that at the outside of trauma diversion, that they're just very clear that if there's any patients with appendicitis or, you know, a gallbladder disease or any bowel disease, they know ahead of time that they're on diversion, and then they identify another hospital that already has a very high workload, like the Peter Lougheed, that's going to have to take those patients from the emerge. Then my colleagues in emerge end up in consult with the surgeons. We'll have to then try to book ambulances to come then. So instead of the ambulances being out in the community to respond to new patients that are sick and have life or limb-threatening illnesses, they end up having to be moved over to be able to take this patient that's in the Foothills Emergency Department to the Peter Lougheed Emergency Department, where then they get seen again and then go to a surgical group there. That's an example. What I want to highlight and put a point on is that this has become so common. We have a policy for it. We actually have a process that everybody's aware of and that we do regularly. And it's become this, you know, basically a normalization of deviance. This is not our normal practice, but we've normalized it because it's so common. And I think, to put a point on what Dr. Mack said earlier, is we're aware of that policy and how we're trying to mitigate this potentially disastrous kind of growing problem in the province, but we're not fully aware of how we're going to intervene to break that cycle so we don't have to use that policy anymore.
Thank you. Tina had raised her hand or submitted via chat. So Tina Kennedy, please.
Thank you. I just have one last question. I mean, aside from COVID, we know COVID exacerbated many problems, but what's the root cause? I mean, is it political yo-yoing on healthcare? I mean, you guys have been studying this for a while. What do you see as the root cause?
That's $1 million question. I do think in Alberta that the environment, this has been growing for a long time. Some of this has been delayed investment and some of the upfront issues. Some of it has been, with healthcare, it's a complex system, so it's not like I can give you the solutions, and the answers are often quite complex and multifactorial. And so there's lots of pieces of migration to our residents. 15, 20 years ago, when Dr. Mack and I were residents, we provided a lot of service in the hospital. Over time, that has changed for good reasons. They've made focuses on training, and these are doctors in training and providing education and less service. That's the reality we're in now. So we have to actually have service providers that are identified and paid and incentivized for it. There's pieces like the fact that we are not any longer incentivizing doing the difficult after hours care compared to doing the regular 9 to 5 clinic type care. Lots of different pieces go into that, but I'll summarize. I'll say two things. I think that the fact that there was an environment pre-COVID where the ministry and the government actively attacked the profession and tore up our contract, it created this area where nobody wanted to come into our province for a long time. Then pandemic sped that up by a factor of 100-fold or even more in terms of burning out some of our workforce. And now we're truly in a reality where our workforce is so depleted and we have such booming population, 200,000 new patients coming into the province a year. That's unprecedented. And they come with illnesses. They come with appendicitis, with bowel troubles, with trauma. And we're in a scenario where we have a depleted, demoralized workforce and unbelievable volumes. And it's just not a time that there can be budget constraints to not invest in those upfront solutions that's going to help us get out of this problem. That is a very big, broad question. And in a nutshell, that's as best as I can give you a quick summary on. I don't know if Dr. Mackey you can add to that for sure, I think.
I mean, from a surgery point of view, the only thing I can add is the budgets were frozen for a period of time during the last decade. So there was actually no new hires for quite a period of time, no new surgeons, despite the population growth. And similarly, I'm assuming there was similar hiring freezes or held on tier 1 supports because of budgeting primarily. Probably because we all weren't expecting this huge population change.
We're coming up on the 50-minute mark. We have 2 questions remaining on the board. Gentlemen, do you have time to take the last 2 questions and then we'll call it a morning? All right, back to Jennifer Lee then, please.
Thanks. This one is kind of a bigger picture question, but Dr. Mack, you mentioned potential implications of these diversions in terms of, you know, the delays and complications potentially even could result in death. Have you seen, excuse me, have you seen situations where these negative implications are happening? And if so, how much of a safety concern is this situation to you personally?
Yes. So the hard part there is even my last night on call, I'm aware of 5 patients who were diverted, at least spending an extra 8 to 10 hours before timely surgical care with real problems. You know, I can only surmise that leads to more complications because it's really not within our guidelines or in our ethics to make people wait that long when they have real problems. So yeah, it does affect, you know, I'm not personally aware of deaths, but I know it must be happening. With the frequency that this has been going on, it must be happening.
Yeah, and I'll add for that. That's a hard one though, Jen, because so there's no question that delaying the surgical care increases morbidity and complications, and I've been through this a lot in terms of delays to emerge care. It's often hard to say if someone had a really complicated disease and it got delayed, their surgery didn't occur for 10, 12 hours, and then they get sicker and have sepsis and go to ICU and spend a couple of days and then pass away. Did that cause their death? Did the delay cause their death? And I'll say that's very hard for us to say, but what I will say very clearly is all of us, all of my general surgery colleagues and physicians across know that delays to timely care in acute and life-threatening kind of conditions never make it better, and it often really complicates it and makes it worse. And I think we're all growing aware of more and more bad outcomes and very significant bad outcomes, and are hearing of some deaths that are occurring because of the diversions, but they're not normally like, we don't have the specifics that we can share and give the data. It just suffices to say that we're all very, very concerned that this is having very negative and significant impacts on our burdens.
Thank you. Last question to Global. Clarice?
Yeah, thank you. And sorry, this is really off topic, so I apologize. But we're doing a story on Paxlovid and the access to that because it's been reduced and it's now costing $1,400. Are you worried that folks needing that kind of treatment are going to end up in your hospitals?
Well, I'll answer saying that if definitely, in broad terms, there's no question that if people need access to medications that will decrease their morbidity and mortality, then very concerned if cost is the rate limiting step for them to get it. So I don't know any specific details. I can't comment on changing Paxlovid or the indications or recommendations or why they're making those changes right now. But I'll just say in general terms, absolute concern if someone needs a medication and it's medically indicated and will decrease their morbidity and mortality, then I strongly believe that a cost should not be the rate limiting step as to why the patient could get that care.
All right. Well, thank you all for coming this morning, and wish you well with the rest of your day. Thanks to our doctor speakers, and we will sign off for now. Thank you.
Thank you.
Thanks, everyone.
Thank you.